Wonderful. Hello, everybody. Thank you for joining us. I'm David Alexander, current president of the Myeloproliferative Education Foundation, and I am pleased to have, at last count, I think nearly 200 of you here to join us for a program that Joanne Menino has put together for us. Many of you know her, and even more of you know Dr. Ruben Mesa, who has put together a world-class panel for you. He will kick off the program and then introduce the remaining three speakers. Dr. Mesa, it is all yours.
Wonderful. Well, David and Joanne, it's really a great pleasure for us to be here today. As many of you know, today is MPN Awareness Day, and that's really an international phenomenon. Indeed, I think the awareness regarding these diseases, as well as the tremendous global community that all of you have helped to build, is really something to celebrate. Indeed, have greatly enjoyed working with the MPN Education Foundation now for many years, going back with a long tradition of close partnership and friendship between patients, patient advocates, their loved ones, and us as an MPN scientific community. Now, we all know that one of the cornerstones of this set of activities in the MPN Education Foundation, as well as the wonderful online community that they help to create and support, has been the every 2-year meeting that we have enjoyed together in Scottsdale, Arizona. And indeed, as you all have heard, sadly, we predict that getting together in person in February is really not feasible for a variety of reasons. And we certainly hope to regather in person and celebrate in that wonderful venue when the time is right, whether that's at the end of 22 or 23, or when the time is right and people can thoroughly enjoy that. But all of that said, the importance of getting together, of communicating, of sharing the advances in MPNs is as great as it has ever been. There is a tremendous amount of things to be hopeful for, new information, new therapies, better understanding of our prior therapies, and yes, the discussion of MPN and COVID itself, clearly of great interest and highly relevant for all of you. Now, as with all of these events, they really are built by us having the wonderful participation of tremendous friends and colleagues who are experts in MPNs, bringing in their time, their talents, and their efforts for us to get together, discuss, and share. So tonight, what we've planned is a 90-minute symposium. It'll be very low-key. It'll be a few talks to begin with, and then time for us to really be able to interact as well as answer your questions. So we're joined tonight by my wonderful friend across the pond, Claire Harrison. She really needs no introduction. She is a wonderful, long-standing professor and international leader in MPNs. Just to detail her accomplishments would take more than the 90 minutes. But Claire's going to give us some key updates on ET and PD. And a special thanks to Claire, as this, of course, is quite a few hours in the future in London. So she's doing this at the end of a long day, and we really appreciate her participating. Next, Aaron Gerds, who is, again, similarly wonderful friend and colleague from Cleveland Clinic. He currently chairs the NCCN guidelines panel for MPN therapy in the U.S. And brings a tremendous experience to our discussions, and we'll be talking about those treatment guidelines, how they're evolving, as well as demystify a little bit of that process on how guidelines are developed and why they matter. And then finally, my cohort in crime, Dr. John Mascarenhas, he and I helped to co-lead the MPN Research Consortium clinical trial initiatives, been a friend for decades, and he will be giving us a status update on new drugs in myelofibrosis. And then we will be opening it up to questions. Now for myself, I assigned myself the topic that really is on the top of most people's minds, and it's a question with every patient I visit with, and that is, what do we know at the current time with MPNs and COVID? And I'll share with you as much of what we don't know as what we do, but we will answer your questions to the best degree that we can. And with that, we'll share my slides. Joanne, can you confirm that you guys are able to see my slides okay?
Yeah, we're good.
Yes.
We're good.
Yes.
All right. Great. So first, there's been tremendous ongoing conversation and coordination between specialists around the world, really as soon as this was starting to evolve in the end of February and early March. And a group of us, internationally, Claire and I amongst them, have worked together to develop a series of recommendations for treating physicians that evolve over time as we learn more. This is on the web. This is put forward by the American Society of Hematology. They similarly have information on COVID and recommendations with similar such groups with other diseases, as well as information in general. So some of the information I'm sharing with you is from a range of colleagues. So the first question is, are MPN patients at higher risk of COVID-19? And it's a complicated question in that when we think about risk, there's really two things. One, are MPN patients more likely to develop COVID than the general population? Or the separate question, are they at greater risk of having a severe case of COVID than the general population if infected? So first, it is not clear that MPN patients acquire COVID at a greater rate than the general population. It's difficult for us to know for certain because of very limited ability to really have the data in terms of comparison. But there is no clear evidence that it is at a higher rate. Now, there are some information that do have some concerns regarding the second piece, regarding if you have COVID, is the situation more serious? Now, we do have some information that has been put together in an expert way from our colleagues in Italy that are helping to publish and put this data out into the public domain. Now, it does have to come with a caveat in that Italy, being in the very beginning part of the severe aspect of this wave, were both overwhelmed in terms of number of cases to the resources available, as well as were learning very much early on in the process. So it is possible that some of the difficulties, concerns, and rates of complications that they saw in Italy might be less as the situation has evolved, as there were more resources, as we learned that blood thinners potentially can help to avoid some complications, as new drugs became available, such as remdesivir and other antivirals, as it was appreciated that steroids might help with anti-inflammatory properties with pneumonia. So many aspects that have evolved. There was initial concern regarding MPN therapies. And as things have evolved, it has not been clear that being on an MPN therapy would increase your risk of having a worse outcome if you develop the COVID infection. One thing that was identified that is a concern is that in Italy, they found very sobering data that suggested that if individuals had been on ruxolitinib and then discontinued ruxolitinib, then they had much greater risk with the COVID infection. So that stopping JAK inhibition in the setting of becoming infected was probably not a wise thing to do. Another thing we have learned along the way is that COVID is associated with a higher risk of blood clotting events. This is independent of being a patient with an MPN. And our colleagues in Italy did find that that continued to be the case for their patients with MPNs. There are ongoing efforts to try to determine, does this mean we should intervene in some way with blood thinners with MPN patients that are affected? I don't think anyone can answer that question definitively, but the answer is at least a maybe and needs to be a consideration between the treating physicians and the patient if they become infected with COVID. Severe cases of COVID, now the standard has evolved to largely anticoagulating patients who are sick enough to be hospitalized with COVID, pretty much even independent of MPN status. But in outpatients or milder cases, it is still not known, but it's a discussion. Now, what about medications? Well, this has evolved. At the very beginning part of the severity of the pandemic, when we were discussing these things in March, we had a concern, again, if people were on drugs like interferon, Hydrea, ruxolitinib, were they more immunocompromised, and should we be more modest in terms of either the dosing or the goals with these therapies? I think as we have evolved over time and we have come to recognize the importance of the risk of blood clotting or bleeding events for individuals that have COVID, we have to some degree modified our recommendations to say that you are probably best off during the time of COVID if you are adequately treated for your MPN. You don't have to be overtreated, but if the goal is to get your counts within a certain range, your hematocrit under 45, your spleen well controlled, your symptoms well controlled, it is that much more important in the time of COVID. It is my at least personal belief, in the absence of absolute data, that the more in balance we have you with your disease in terms of the control, probably the better off you are to either fend off the illness, or if you have the illness, to have a good or a reasonable course. Now, there has been speculation that interferon might have a protective role against the COVID virus. At this point, we do not know this to be a fact, but it is at least theoretically possible, meaning interferon does have antiviral properties. Its name of interfere is interferon because of its antiviral properties. So we don't want anyone thinking that because they're on interferon, they shouldn't wear a mask, they shouldn't wash their hands, and do all of the things we should do in terms of social distancing. But there is at least a possible benefit. Now, what about JAK inhibition? Again, I had mentioned that it has been identified from our colleagues in Italy that stopping JAK inhibition in the setting of someone who has become infected with COVID is probably not a good idea. JAK inhibitors have some anti-inflammatory properties. And one of the reasons that COVID makes people as ill as it does is that the viral infection leads to a secondary pneumonia in the lungs with very significant inflammation that can affect both the lungs and other organs in the body. So it has been thought that various anti-inflammatory drugs may have a beneficial impact. there have been now trials showing that ruxolitinib may have a benefit in COVID-related pneumonia in trials even independent of those who were even independent of MPN patients, in fact, largely in non-MPN patients. So at the current time, we are recommending, again, that people be treated as they should be treated and with the appropriate dose, and in particular, to avoid abrupt interruptions with ruxolitinib. There's a range of experiences that are out there, and certainly as we get around to the Q&A, we have people with tremendous experience from all of our panelists with having to care for way too many COVID patients. But certainly there's at least anecdotal experience that some individuals who've been on ruxolitinib may have had a better disease course, but of course it's difficult to know. Now, new patients, again, we are, trying to optimize therapy as would be normally received. And again, we'll be talking about each of those in the NCCN guideline piece as well as the other talks. Now, what about if you have the COVID infection? Again, I think the main theme I would want to get across to you is that your whole healthcare team should connect if you do, in fact, end up developing the COVID infection. Your hematologist, your internist, or God forbid, you're ill enough that you have to be in the hospital, your hospitalist, etc., they should all really be communicating regarding any possible drug interactions. This was seen in Italy, again, as antiviral therapies were used, and these are drugs that were not normally on or that hematologists don't usually use in routine practice. So to be mindful of drug-drug interactions, but also in terms of any modifications of dosing, and that other issue that I had raised before regarding whether or not blood thinners such as low molecular weight heparin or others should be considered. Again, individuals that are already on blood thinners such as warfarin, there certainly is a consideration whether they might be better off being switched to low molecular weight heparin. That was some of the experience that had been identified from our colleagues in Italy, where patients were transitioned to low molecular weight heparin to hopefully have easier adjustment of their medications. Now, I'll conclude with some preliminary data from a survey that many of you might have participated with, as well as my colleagues on the call here and many patients from the UK, along with our colleagues from Mayo. And this was a survey that we plan to update with other experiences, really regarding MPNs and COVID. And we had over 1,500 patients respond to the survey. Over 1,200 were eligible for the analysis, with a bit female predominance. That tends to be not uncommon regarding responding to these sorts of surveys. Breakdown by disease, as you see, many of them with MPNs for a longer period of time. And the majority at the time of the outbreak were on MPN therapy. And as we see, the majority now have had a telemedicine visit with their care provider after COVID-19. We have seen individuals suffering tremendous amounts of distress, much more than typical. And again, this is not only because of their disease, it's because of the crisis we've all been undergoing, but probably exacerbated by having a chronic illness at the time of this global pandemic. Indeed, as we look at that median MPN symptom form, 26 is really quite a bit higher than normal for this for the MPN-10. The majority, or near the majority, are in a community with a significant COVID spike. Yet we see it's a relatively small minority that have had COVID testing. And this is the fascinating part. And again, it's difficult to know because of the way that this is done. but only 5 had positive tests for COVID at the time of completing this survey. We're going to be updating this. This might underrepresent individuals that were sick. They might have been too sick to participate. They may not have known about it, but it is surprising in terms of the few number of positive cases. Now, we also looked, there were free comments that were able to be put in. And again, we're analyzing those to learn more about that. And what has it been like for all of you to go through this with the added complication of having an MPN? We saw that there were many aspects on care that individuals thought was negative. There were some that were thought that were positive. For many, particularly being able to interact with their, let's say, kind of consulting hematologist who lives at a distance by telemedicine has been viewed to be a big plus. But the lack of kind of the direct connection with the healthcare team is frequently as a negative. There have been delayed or canceled doctor visits, inaccessibility to regular providers, and other difficulties. So again, much analysis that is ongoing and much serial analysis that will need to undergo as we really track more and more patients that have been gone through COVID themselves and what that experience was like. So I'll conclude by this. An uncontrolled MPN by undertreatment probably increases COVID risk. MPN patients are not severely immunocompromised, but it's likely at least some have a higher risk than the general population. I certainly stress for all of you, as I do for everyone who I care for, to take all of the recommendations seriously. This is a serious illness that none of us want to acquire. And the sooner we have a way to try to protect all of ourselves by effective vaccines, the better off we are. I'm deeply hopeful that Claire's colleagues at Oxford were successful with their vaccine, and if not them, hopefully someone else very soon. Maintaining patients on stable therapy is advised, and low molecular weight heparin might be an important consideration for MPN patients if affected, especially if they had been on oral anticoagulation. So that I will hopefully successfully stop sharing and then hand it over to Professor Harrison to give us some updates in ET and PV. And again, we'll be having questions at the end. We have some that have been pre-submitted and others that can be submitted as the conference continues forward. Thank you.
Well, thank you very much, Ruben. Very eloquently put, and indeed a time of a lot of challenge, but it means that joining together through these kind of media are really very helpful, and I'm really grateful for the opportunity to join with you, albeit at a late hour in the UK. So you asked me to speak about updates in ET and PV, and I start with this very nice slide, which was lent to me by Alessandro Vanucci, where he really emphasizes all of the different kind of nodal points that we use in managing your diseases. We established a diagnosis, think about risk, and for ET and PV, really, currently we're thinking about risk of thrombosis. And just to emphasize, with regard to coronavirus, of course, we are treating you to minimize your risk of thrombosis. And so it's really important that we optimize your treatment. We personalize it to you, to your own individual circumstance. There may be for example, specific reasons why one therapy might be better than another, evaluate the response, manage special situations, for example, pregnancy, surgery, and then reevaluate, looking for how we can optimize treatment further and screening for evidence of toxicity or disease progression. So I really like this slide because it kind of puts across the concept of what we try to do in day-to-day practice. I'm going to focus first on PV, and I'm showing here some of your work, Ruben, actually, and some of the work we've done in the landmark study. And just wanted to highlight here that, we have thoughts about treatment, but sometimes our treatment choice is limited according to what's available, something about demographics, that means previous diseases or other for the patient. Sometimes it's also the experience of the physician. We can't help it, but if we've previously given a patient a drug and they've had a bad reaction, that's going to affect our decision making to some extent, and also your choice as a patient. In the bottom half of the slide is the work that was done by Ruben and some of the rest of us outside North America in the second landmark study, asking about priorities for treatment. So on the left, you see the kind of pie chart of what the physician's priorities were for patients with PV. They want to prevent vascular events. They want patients to have symptom control. They definitely want their hematocrit or patch cell volume to be less than 45. But they're really not focusing so much on slowing or delaying the condition, perhaps because that relates to what we can achieve with the disease. On the other hand, when patients were asked, patients clearly understand the risk of a vascular event, and they really definitely want that addressed, but you also want a treatment to slow or delay the condition, and this is something that we need to focus on going forward. Patients want healthy blood counts and better quality of life. So it's important to be aware of this difference in goal or perhaps perception. And the basic ABC of treatment for polycythemia vera is actually based on a lot of evidence and a lot of different trials, some of which are very old, such as the polycythemia vera study group, and some of which are much more recent, such as the PROUD PV study, and the study which ran across Europe and North America, led by John and yourself, Ruben, in the MPDRC study, comparing hydroxyurea with interferon alpha. So we will be using aspirin and phlebotomy as a cornerstone of therapy, and for higher risk patients, we'll be adding a drug such as hydroxyurea or interferon. And for all patients, we should be managing cardiovascular risk factors, and that's something I'm really trying to focus on right now in London for my patients, because these are risk factors also for coronavirus, managing obesity, managing hypertension, etc. So more recently, there has been a focus, and this comes really from Professor Barboui, whose slides these are, upon patients with low-risk PV. So this is generally patients who are less than 65 years of age and have not had a thrombosis or blood clot. And what he's essentially showing here is that whilst for high-risk patients, as you see in the top, those patients diagnosed before 2005 had a risk of thrombosis of about 4%. This fell after this time, but for low-risk patients, this hasn't really changed, whereas it has changed for the general population. So the risk, calling a patient with PV a low-risk patient, you need to really acknowledge that your risk is still double that of the general population. In the background of this is the data from the PROUD PV study, which was the study carried out in Europe, by Heinz Gislinger, Jean-Jacques Kilagin, and others, randomizing patients with PV at the time of diagnosis or treated for less than 3 years to either receive Ropeg interferon, which is a new formulation of interferon called Bestremi, or hydroxyurea. There was 12 months of treatment and a readout, and then a rollover study known as continuation or CONTI-PV. In this study, the endpoint or the target was to control the blood count, to be free from phlebotomy or venesection for at least 3 months, to have a platelet count less than 400 and a white count less than 10. They also evaluated spleen size and symptoms as well. Now, actually, the two therapies were equivalent in terms of achieving control of the blood count. And what I wanted to point out here was the issues with regard to thrombosis or clotting events. So the rates over the entire period, and this is a 4-year analysis of this study, was 3.1% for both arms per year. And here you see a little breakdown of patients. The top half of the table is the row-peg patients and the lower half, the control arm. And what I really wanted to point out to you was that the majority of these events occurred in patients who were not in CHR, i.e. their blood counts were not controlled. So here you see there were 6 of these patients, these 9 patients, who did not have control of their blood counts at the time of the event. Now, another major finding from this study, which I want to move on to, is the idea that interferon, in interfering with the disease, is able to induce what's called a molecular response with a fall in the quantity of abnormal JAK2. And here you can see that the depth, so the amount the JAK2 V617F is reduced by, is much greater in the interferon-treated patients here that compared to the control group. And here's just a graphic representation of this. Now, this idea of reducing the amount of the abnormal gene is actually quite common to related diseases such as chronic myeloid leukemia. But in the MPN field, we haven't really been able to show that this correlates with a benefit for the patient. In other diseases, we know that if we get rid of the abnormal clone, the patient usually, for example, will live longer. This is true for patients with leukemia, for example. In a recent year, in the UK, we've been carrying out a study called the MAGIC PV study, and we were studying quite a large number of patients treated second line with ruxolitinib or a second line agent and looking at molecular endpoints. Now this data I'm going to show you is regardless of the treatment the patient had. Those patients who achieved a molecular reduction in JAK2 didn't have to go away, it just had to reduce by about 25%. It didn't correlate with how good their control of their blood counts were. It didn't correlate with bleeding events. But importantly, and this is the work of Natalia Curto Garcia, who's a fellow with us from Spain, and her work showed that those patients who had this reduction in allele burden didn't have a thrombotic event, in contrast with the fact that almost 20% of patients who hadn't responded did have a thrombotic event. And those patients who had an increase in their allele burden were also more likely to have a thrombotic event. And also importantly, going back to that colourful pie chart, those patients who had a reduction in the amount of JAK2 appeared to have a better, what we call progression-free survival. So their disease was less likely to progress. So here you see a graph showing that. So this is first of all comparing best available therapy, or BAT, with ruxolitinib. You can see no difference in these two curves here at any time during the study. And here you see the outcomes for patients according to whether they had molecular response. So for the first time here, we're able to show in a study that patients who had a reduction in their allele burden were more likely to go on with their disease in a chronic phase without change, for example, to myelofibrosis. Now, this needs validation, and once our research labs are opened up again, because they've been closed for a while now in the UK or turned over to doing COVID research, we'll be looking at later time points in this study. Now, building on this, then, Professor Barbouri has taken the idea of looking at low-risk patients with PV and treating them with row-pegylated interferon, or Besremi. And in this study, patients were low risk, so they were aged between 18 and 60 without a history of thrombosis, and they were all treated with phlebotomy and aspirin, and they were randomized to either receive interferon or not. And the endpoint was response in terms of freedom from phlebotomy. Non-responders were able to cross over. But interestingly here, the primary endpoint was better for patients treated with interferon, also better in terms of hematocrit control. So for me, that wasn't so very exciting, because for me, it didn't seem that surprising that you got better blood count control if you were on ropeg interferon. But the stronger message comes here in terms of disease progression, which basically was a significant rise in the platelet count. And there is a patient here with a splenic infarction as well. And also this analysis, which is a way of showing what happened to the patient's symptoms. So you see that on the whole, most patients achieved an improvement in their symptom score. So here's the mean change in symptom score. So anything below this line here was basically a reduction in symptoms. Little bit disappointingly, fatigue got worse with the interferon, but that's probably not so surprising. So this is a really important interim analysis, and I'm really excited to hear more about secondary endpoints and longer term follow-up of this study. But I think it also reinforces the message to clinicians that symptoms could be an indication for treatment in low-risk patients. And that's certainly something that I took away as a message from this study, and I'm sure we'll be discussing this in the coming minutes. Also presented at EHA, the European Hematology Association meeting, which was entirely virtual, as indeed ASH will be this year, was some data looking at the mechanism of action of interferon in patients according to their mutation status, which is absolutely fascinating. Don't have time to go into it today, but I'm sure this will allow us to understand more about how to get molecular responses for our patients. You asked me also to talk about ET, so here are a few slides on this. And basically, you can think about ET in the same way that I just described treatment for PV. We think about low-risk patients having aspirin. Of course, we don't need to phlebotomize for these patients because they don't have a high hemoglobin. And for higher-risk patients, we would give either or interferon or hydroxyurea, or we may choose to give anagrelide. In a revised risk score known as IPSET, cardiovascular risk factors also come into play, and patients are actually divided into 4 risk groups. Very low risk, where perhaps they don't need aspirin, low risk, intermediate risk, and high risk. And this is helpful, but it hasn't yet really refined our treatment processes. And I think one of the things we need to be thinking about is who needs aspirin and who doesn't, and a little bit more about what this intermediate risk group looks like, and perhaps a little bit more about what the high risk group looks like. I think in the future, we might think about CALR mutated patients slightly differently to JAK2 mutated patients. For example, on the left, here's the results from the ECLAP study in PV showing that low-dose aspirin reduces the risk. So here are patients treated with aspirin who are not having events compared to those patients treated with placebo. And on the right, across Europe, we collected data on our low-risk ET patients and showed the benefit of aspirin in terms of reducing venous thrombosis with no risk of bleeding for JAK2 mutated patients. But for patients with ET and a CALR mutation, the risk of a thrombotic event is much lower. Therefore, the benefit of aspirin is not so well seen, and the risk of bleeding with aspirin appears to be more marked. The mechanism for that is unclear. So there's a question mark about the management of ET. A question mark about patients with progressive thrombocytosis means an increasing platelet count, what the threshold should be. Classically, this is 1,500. Should it be higher in JAK unmutated patients, and what should we be doing with aspirin? This is something we should be thinking about. Meanwhile, in recent times, we've completed a 20-year study in the UK. We started this just before I became a consultant. And here we looked at patients who were low risk, but aged between 40 and 60. And we compared aspirin with aspirin and hydroxycarbamide. So answering the question, Just because patients are a bit older, should we be treating with a drug like hydroxycarbamide? And the short answer is no, because there was no difference in clotting endpoints. And actually, the rate of these endpoints was very, very low. And you can see the different clotting events here. I won't go through them in detail. But also importantly, there was no difference in overall survival. So no survival benefit just for treating the platelet count in patients with ET who are aged between 40 and 60. So to summarize, what are the ongoing issues for us in treating patients with ET and PV? One question mark is, what should we do with the platelet count? Should we be aiming to normalize it? We did that in our UK study. In Bergamo, in Italy, the original data suggested less than 600 was sufficient. So I would bear that in mind when my patients are having difficulty tolerating therapy. In terms of hematological response and how well we control other aspects of the blood count, the benefit of that is not quite clear. Molecular response may well be a marker in the future, and I think it would be really good to validate this data. So we're going to go on and do that in more detail. And then some other questions. Should we really be managing JAK2 positive ET as PV? Should we just keep the hematocrit less than 0.45? What should we do about the pesky leukocytes? And what about looking at additional mutations with an NGS panel? So I'm going to leave it here, leave you with a view from Guy's Hospital across London, and thank you for the opportunity to speak today. And I think I just stopped sharing. There we go.
Wonderful. Well, Claire, well, that was fantastic. And I know we'll have a bunch of questions. Really a great update and some important evolving understandings, especially regarding potentially earlier therapy for a lower risk PV. Next, let's ask Erin Gerds from the Cleveland Clinic to give us an update in the NCCN guidelines for MPN management, what these are, what are some of the changes, and most importantly, how it's relevant for yourselves.
Well, thank you very much, Ruben. And I'm glad we got the technology working. There's some tense moments there with this platform, but I'm thrilled to be here and talk to you a little bit about the NCCN guidelines. I will share my screen momentarily. On top of it, I found out about 30 minutes ago that my slides all were incorrect and an older version of this talk. So this is actually fresh off the presses, literally 30 minutes ago. So I'm going to talk a little bit about the current MPN guidelines, really with a focus of what are guidelines, why are they important, and why should we even bother? Of course, it's in the evening, so I've given the old bow tie a rest. So I do apologize in advance for not having my sartorial commentary type neckwear on, but I think we'll all be able to move on from that. So what we're going to talk about is what is the NCCN? What does it mean? Why does this organization exist? A little bit about the MPN guideline development, what the guidelines actually look like when your care provider opens up the guidelines on the website. What do they see? As well as want to touch on very briefly about the guidelines for patients. So what is the NCCN? Well, it's the National Comprehensive Cancer Network. And I want to make it clear, it's different from what we hear about with comprehensive cancer centers. So NCI designated comprehensive cancer centers mean that they're these cancer centers who have been awarded large grants from the federal government to conduct cancer research and as they care for cancer patients. This is a separate entity. This is a not-for-profit alliance of leading cancer centers across the country, US-based, devoted to patient care, research, and education, and really has a kind of a main focus on quality improvement and efficiency in cancer care. And really at the crux of what the NCCN does are the cancer guidelines. So these are guidelines developed in every disease. So just like for MPNs, there are guidelines for breast cancer and acute myeloid leukemia and pancreatic cancer, where large groups of experts in the field from the representative institutions get together and develop these guidelines. But the NCCN does a lot more than that. There's a lot of quality efforts that they do, looking at how to make cancer care better and increase the value of cancer care. They also have an international presence now. It's not just for North America anymore. They are working to develop guidelines in other countries and work in quality initiatives, in particularly with a focus in Africa. So it is branching out from North America. These are now the 30 member institutions, a map. Again, it does cover the entire country from top to bottom, left to right, with the newest members, UCLA and UT Southwestern shown here. Again, the main kind of product or the main thrust of the NCCN are the guidelines. So these guidelines that any care provider can download to help take care of their patients and improve the quality in their practice, consistency in their practice, as well as kind of get the latest and greatest updates. So these are the number of downloads from the NCCN website from 2006 to 2019. And you can see in 2019, the guidelines were downloaded 11.3 million times. Again, these are all the different disease states, but if you look at the MPN guidelines shown here on the right, since their development in 2016, they've been downloaded 66,000 times. So really disseminating the latest and greatest treatments and information to care providers. So there are 59 panels in total that produce 77 guidelines. For example, the MPN panel now produces 3 different guidelines, one for the classic pH-negative MPNs, including PVET, as well as these group of diseases that are defined by certain genomic abnormalities and eosinophilia, well, that's a type of cell in the blood. And then lastly, guidelines for mastocytosis. So again, our panel actually produced 3 different guidelines. So that's why those 2 numbers aren't the same. There are over 201 algorithms, and we'll see what an algorithm looks like in a little bit. Across the panels, there's about 1,500 members. And in an average year, the members contribute about 3,500 hours putting these guidelines together. So it is no small task to develop these guidelines. It takes a lot of work. And the reason is there are new and exciting therapies coming out for all kinds of diseases all the time. And so these guidelines really have to be nimble and changing constantly to reflect the changing practice. If a drug gets approved in April, the guidelines have to be ready by the end of the month to push out a new version in order to address that new medication that was approved by the FDA or some big study that came out that to change practice. So you can see here in 2020, there have so far been 130 version updates. So not only are there this huge amount of guidelines, but they're constantly being updated. So again, that's where the 3,500 hours is coming from. So we've talked about what the guidelines are and kind of their institution. So what do they look like? Well, you'll see folks like myself or Serge or John or Ruben get up and kind of talk, or Claire, and talk about the treatment of myelofibrosis. And we might show something like this, where we show the symptoms on one side and then the possible treatments you could use. But that doesn't help really narrow down for an individual as a practitioner or a care provider seeing an individual, like what should I choose for this person exactly? This is kind of a vague concept here. So when we get up and give these talks, we'll start to talk about prognostic algorithms like the MIP70 shown here, and we'll talk about low risk and high risk and how that might impact your treatment. And then invariably, we will then show this, an algorithm that we've developed on our own, and plaster that up there. And and this is the gospel truth according to Dr. Gerds, and it's not a very universal thing. So if every person who takes care of a patient with MPN does this, their own kind of version of care, you could see that from center to center, care could get disparate, and there won't be uniformity, and increase and value will decrease in overall patient care across the country. So really, this is why there is a need for guidelines. It brings people together in the center. It helps to reconcile differences and provides a road path for others looking in. So in particular, there are many guidelines that were published in Europe and other places. And in 2015, Dr. Mesa and Dr. Stein and a bunch of others across the country felt that it was incredibly important to develop U.S.-based guidelines to reflect U.S. practice, and that's why we now have the NCCN guidelines. And this is what they look like. This is version 1 2020, so the first iteration for the guidelines this year. And this is the landing page. And at the bottom is this continue button. So the really nice feature about this is it's a PDF, and there's tons of hyperlinks. So you can kind of click right on through as you're trying to diagnose a patient and risk stratify them, and then ultimately find their treatment. So this is the page here where you've already made the diagnosis. On the prior page is a list of tests you would do to make the diagnosis and how to interpret them. And then you get a diagnosis, so you then land on this page and they say, okay, well, the patient that I'm seeing has myelofibrosis. And so then I move to the middle column, and there are the risk scores. And so while I have this particular information, I can calculate the risk score. And then I move to the next column here, and well, they have lower risk. So then I click on that MF1, and that sends me over to the low risk algorithm to help try to parse through treatments for that individual with the lower risk myelofibrosis. In addition to the algorithms within the NCCN document, there's also a long monograph. The monograph is somewhere around 50, 60 pages right now. We are currently updating it, so it's being revised. But it actually has, it's a review paper. It's lots of details on these recommendations. So really, the utility of the NCCN guidelines, you can pull them up, quickly work through the algorithm in a short manner of time in order to initiate care for a patient. And then for additional details and subtleties, you can then refer to the monograph that follows to get those kind of like granular points. In addition to producing guidelines for caregivers that deliver the care to NPN patients, there are also guidelines for patients. Now, these were developed specifically for patients. They're written at a level where patients can hopefully understand them. And they are based and reflect the actual guidelines that the practitioners have. And here's a picture of the most recent edition, the 2019 edition. The cover there on the left. On the right is one of the page number 7, which shows kind of the MPN basics here and cellular development, and kind of gives you a sense of how it reads. So this document is about 70 pages long, and it goes through basics of MPNs, how they're diagnosed, the different disease types, and then different treatments you might use for each of the different disease types. At the end, there are some frequently asked questions and other resources to reference. Also on the NCCN website, along with the patient guidelines, are checklists where you can say, this is a checklist of questions you may want to ask your doctor when you go in, and to kind of help bring you and your care provider together when making treatment decisions. So I think this is a fantastic resource. In fact, I've printed out a giant stack of these, and every time I see a new patient in consultation, I give them a copy of this. Along with my business card and after visit summary. It's really kind of a key part of that initial education on the first visit. So with that, I'd like to thank you. It was a pretty brief talk. I just, again, wanted to really set the frame of what the guidelines are and why we have them, and really why they're so important. And really, it kind of brings everyone together and helps define treatment for a lot of practitioners in North America. With that, I will try to send it on back to the group. If I can unshare. All right. I am still screen sharing. Stop sharing. There we go. All right. We're back.
Great. Well, Aaron, that was wonderful. And again, it's a labor of love by Aaron and colleagues. And it really plays a crucial role because in the US, it really helps to establish what is that standard of care? And that has major implications for what Medicare considers the standard of care, what they cover, what insurance companies cover. So I'll give you an example. Those of you that get Pegasus or pegylated interferon covered by your insurance company or by Medicare, it is primarily because it is in the NCCN guidelines that coverage occurs. So there are so many aspects of that are highly relevant. It also really is a tremendous resource for treating physicians that are trying to keep track of literally dozens of different diseases as to what the standard is. If I am consulting on a patient or get asked about a question for a disease that I'm not commonly caring for, the first place I look is the NCCN guidelines. So if somebody asks me about chronic lymphocytic leukemia, that's the first place I'm going to see what they're doing now. So it really is crucial. So the final piece before we open it up to some Q&A is my good friend John Mascarenhas. He and I clearly have a passion for trying to develop new therapies in myelofibrosis. John, do you want to share with them all the exciting things going on in MF?
All right. So thank you guys very much for including me in this panel, and thanks for Joanne to finally get me hooked up to this because I had a lot of trouble. So hopefully I am going to share my my screen. And Joanne, if you, I thought I understood how to share it, but now I guess I don't.
Okay, so it's the second button from the right. It's the share screen. If you hover your mouse over your video.
Yeah, that's easy.
And then click the first button on the left to focus the screen.
All right, if you can tell me, just assure me that you're seeing my screen.
It's perfect.
Okay, perfect. All right, so so again, thank you for letting me present today. And what I'm going to try to do for the group is update you on new drugs for myelofibrosis. So what I've done here is I've had the pleasure of speaking in person at the Scottsdale meetings previously. And I often get what I interpret as mixed reviews. I get some patients that come and say, you spoke too fast, you gave too much information, and I couldn't follow it. And then I get patients who tell me, oh, I would have loved to have heard more, details and more of the science to better understand it. So I'm going to desperately try to balance the two and neither talk down nor over talk to the patients. And I would encourage, if any patient or caregiver is not following what I'm saying, I apologize. I'm very easy to get in touch with, and I can provide my email if there's any specific questions. But this is my go at it. So this is update on new drugs for myelofibrosis. In keeping with tendencies, I have my disclosures here. So I'm a highly conflicted investigator. I do receive research support and do work with many pharmaceutical companies. And to start with, so this is my the way I would envision the road to JAK inhibitor development right now. And this slide's been shared and presented at many meetings. And what it paints for the viewer is the fact that there have been a number of drugs that are JAK2 inhibitors. Some hit other targets that have been evaluated over the last decade or so. In red here, many that have unfortunately failed due to toxicity issues or just lack of an adequate efficacy. Some that are still in clinical development. And then some that are in late phase development, which we'll mention, like pacritinib, momelotinib, and now there are two in the U.S. approved drugs, ruxolitinib and fedratinib. Now, ruxolitinib has been around since 2011 and fedratinib since August of 2019, and both are JAK inhibitors that are widely used. I won't spend much time talking about ruxolitinib since probably most of you have heard about it or on it or are aware of it, particularly with myelofibrosis, but even polycythemia vera, but I'd like to review some of the other drugs in this area. So the first one, which I'll quickly go through, is fedratinib, which is a JAK2 selective inhibitor, inhibits other enzymes like FLT3 and other signaling receptors. And this drug has been evaluated both upfront, so in JAK inhibitor naive patients, but also second line in patients who've received ruxolitinib. And here I'm showing you the study design of what's called the Jakarta-2 study, which was the phase 2 study of patients who had previously seen ruxolitinib for at least 14 days, who had a platelet count of at least 50,000, and everyone received fedratinib at 400 milligrams daily. There was no control arm. It was a phase 2 study. And the point of the study was to evaluate whether patients who had seen ruxolitinib previously could enjoy benefit from another JAK inhibitor, fedratinib, as a second-line agent. And the investigator was able to classify the patients into two groups, those that were seemingly resistant to ruxolitinib and those that had intolerance issues. And the bottom line is, and this was re-reviewed by Claire and Ruben and others, the bottom line is, and I'll focus your attention here, is that approximately 30% of patients in a rigorous fashion enjoyed what's considered the hallmark of response, which is a 35% spleen volume reduction from baseline or a 50% reduction in total symptom score. And I want to point something out to the viewers that I always think is really important to keep in mind. One might look at that and say, oh, 30%, a third of the patients. So, that's not the majority of the patients who had that response. However, if you really dig deeper and really look at what are these are called the waterfall plots of both spleen volume reduction or symptom reduction in both cases, whether it's the intention to treat populations, all the patients, irrespective of any caveats. There really was a spectrum of reductions, and although the 35% reduction is considered the hallmark, many patients, even with a 10% reduction in spleen volume, will enjoy benefit both from a symptom standpoint, from ability to eat, reverse discomfort, and early satiety. So many patients enjoyed that response, and it was irrespective of whether they're resistant to ruxolitinib or intolerant previously to ruxolitinib being Jakafi. So this was a study that clearly showed the activity and benefit of another JAK inhibitor provided after, quote unquote, failure of the first JAK inhibitor, ruxolitinib. It's now approved in the United States, and one could feasibly use this up front. The label does not exclude first-line use of the drug, but many in the field are using it for patients who are losing that response. Their spleen is getting bigger on Jakafi, or their symptoms are returning, and this is another alternative that's commercially available. The freedom studies are important studies in my mind because it allows for more clarification of tolerability and efficacy and toxicity profile. And these are studies that are going on both in the US, the Freedom study, or the Freedom 2 in Europe, which is a randomized study. But I would encourage patients, as I normally would, if you're able to join the study, there are definitely certain benefits like free drug, and you don't have to wrangle with the insurance company. But also, I have always thought that patients that are enrolled in study are observed and watched more closely and perhaps do better than patients who are treated outside of a study. The next drug we'll highlight is pacritinib, which is another JAK2 inhibitor. It is also in late-stage development. And what I'm showing here is a PAC-203 study that Aaron presented at ASH last year. And this was an important study because it was a dose-finding study. Pacritinib has already completed phase 3 studies. It's been shown both in what's called the PERSIST-1 and the PERSIST-2 study to have efficacy in reducing spleen and symptom, but there were concerns the FDA had regarding bleeding and cardiovascular events that warranted looking and exploring at lower doses and looking at what's called pharmacokinetic studies to try to optimize the delivery of this drug. And where this drug has really found its niche is in patients with low platelets. And this study was originally designed to look at 3 doses of pacritinib in patients with platelet counts less than 100,000. In the case of PAC-203, those patients who had already received ruxolitinib. And again, I just want to bring the audience's attention to where I've circled. So for patients who have particularly less than 50,000 platelets, the response, that 35% spleen volume response, was 17%. So these were patients who would normally not be eligible for ruxolitinib or fedratinib due to the low platelet count, but could have this, what appears to be less myelosuppressive form of a JAK inhibitor at 200 milligrams twice a day, which was probably the winning arm in the randomized phase 3 studies that were previously done, and allowed CTI Biopharma that runs these studies to move into the Pacifica study, which is now the ongoing randomized phase 3 study of patients with platelet counts less than 50,000. This is unmet need. Many of these patients, some may be on this call, don't have reasonable options often because the platelet count limits their ability to receive other therapies. And this drug would be an option for those patients. And patients are randomized 2 to 1, so you're more likely to get pacritinib to physician's choice, which is determined prior to enrollment with the primary endpoint of spleen volume reduction. So for those patients with low platelets, this is something hopefully that will be available to you in the future, and I would encourage patients who have the opportunity and are willing to enroll into the Pacifica study. Momelotinib needs to be mentioned. This is a JAK1/2 inhibitor, similar to ruxolitinib, but differences that we've learned early on in the development of this drug, and this is from the Simplify-1 study that was published by Ruben and others, that this drug, which is evaluated both after, before Jakafi and after Jakafi, perhaps stands out differently than the other JAK inhibitors in this key slide here, which shows that in patients who receive momelotinib, the oral JAK inhibitor, this is in blue, you can see their mean hemoglobin appears to increase and stay in a sustained fashion, increase over the 24-week core study period, whereas patients who get ruxolitinib, which we've known for years, tend to have a lowering of their hemoglobin, which stays stable, but lower than what it starts. So for patients with anemia, this would become a very attractive JAK inhibitor option in which one could try to address symptom and spleen, but at the same time perhaps not induce treatment-related anemia and perhaps even improve hemoglobins in a subset of patients. So this would be an added benefit to the armamentarium that we have in terms of the JAK inhibitors. And much like pacritinib, the Momentum study is evaluating momelotinib in a randomized phase 3 study, hopefully the pivotal study that will lead to the approval of this drug as well, which is compared to a drug called danazol, which was mentioned earlier in one of the talks, which is a male synthetic androgen, which is known in about 20 to 40% of patients with myelofibrosis to improve the hemoglobin. So it is the comparator arm to this in this randomized phase 3 study where you're more likely to get the study drug than the control arm. And the primary endpoint here is reduction in symptoms. So this would be my summation of the JAK inhibitor part of my talk. So first line, for those myelofibrosis patients with low platelets, I would look forward to a world where we could give you pacritinib to deliver spleen and symptom improvement and not compromise the platelet count. Otherwise, ruxolitinib or even fedratinib, for that matter, could be given for platelets above 50,000. And then for those patients, particularly with red blood cell transfusion-dependent anemia, momelotinib would be a nice choice for those patients. Similarly, in the second line, of those patients who had failed ruxolitinib, one could envision a similar algorithm, but where the rest of the talk will go is these JAK-based combinations or novel agents that are being evaluated. It's worth mentioning a drug by the name of luspatercept. This is an injection. For those patients out there who've received ESAs, erythropoiesis stimulating agents like Procrit or Aranesp, this is considered an EMA, an erythropoiesis maturation agent. It's given in a similar fashion as a subcutaneous injection every 3 weeks. And the point of a drug like this is to try to alleviate the anemia, to try to affect the way red blood cells are, or improve the way red blood cells mature in the bone marrow to improve the hemoglobin. In this kind of complicated slide here, this is the study design. It's really 4 cohorts of patients. Those that were not receiving ruxolitinib, shown here, those that were already on ruxolitinib, and then it was stratified by patients who were getting red blood cell transfusions or patients who had anemia but weren't necessarily red blood cell transfusion dependent. So you can think of it as 4 different subsets of patients. And the drug, again, was given and could be titrated up every 3 weeks as a subcutaneous injection at the study center. And at day 169, benefit was evaluated in terms of improvement in transfusion dependence or hemoglobin number. And I'll just bring your attention to what I always think was the sweet part of this result, which is in approximately 30% or a third of the patients who were treated on Jakafi who got this drug, they gained transfusion independence, and 50% of patients had some improvement in their hemoglobin or reduction in transfusion burden. So it would suggest that there are definitely patients out there that could enjoy the benefit of luspatercept, even added on to Jakafi to improve hemoglobin levels. And this drug is now approved for myelodysplastic syndrome, so there may be patients out there that have even received this off-label as a drug in a non-clinical trial setting. But this study will continue and will hopefully be evaluated for approval for myelofibrosis as well. I'll now move into an area called epigenetics, and what I'm showing you here is somewhat confusing, but I think very interesting, and I think patients can appreciate that we often evaluate drugs, and this is, I think, important. We evaluate drugs often in mice that are engineered to have myelofibrosis, either genetically or transplanted with myelofibrosis cells from patients. And with those mice, we study drugs based on mechanisms that make sense, that lend itself to the biology of the disease. And this is an example of a study that was reported by folks at Memorial Sloan Kettering that showed that when you combine 2 drugs, namely a JAK inhibitor and a drug called a BET inhibitor, in this case, a drug called JQ1, you get synergistic or greatly improved parameters of the disease. So for example, if you give a vehicle, which means a control, you still have a lot of fibrosis in the bone marrow of the mouse who has myelofibrosis. If you give JQ1, the BET inhibitor, which I'll describe, you get reduction in that fibrosis. Even in ruxolitinib, you get reduction in that fibrosis. But it looks the best when you combine the two. And there's reasons why that may be, because they converge on pathways that are relevant to the pathophysiology of the disease. And the same was seen, if you look at the spleens of the mice that were treated, the best reduction in spleen was given in the combination. And the best reduction in the amount of mutant cells that were circulating in the mouse were also reduced when the combined JAK inhibitor and JQ1 were given. So this is predicated on the idea that many myelofibrosis cells are silenced, or their activity is silenced by mechanisms called epigenetic alterations. And BET inhibitors, namely CPI-0610, an oral drug, is a drug that affects the transcription or expression of genes in these myelofibrosis cells that govern certain pathways that are important to the disease biology. So for example, genes like MYC or BCL2 that govern cell survival, or genes like NF-kappa B that govern a lot of things, including the production of cytokines and inflammation, or genes that govern fibrosis. And these, the effects of CPI-0610 and the effects on the epigenetic effects of the drug can affect multiple aspects of these signaling pathways that are important, that keep the myelofibrosis cells happy. And what we want to do is make them unhappy. So giving these drugs will actually affect changes in those cells that could be beneficial. And for that reason, in the model that I showed you in the mouse, a company called Constellation created a study called Manifest, and there were 3 populations of patients that went on the study: those that had been on ruxolitinib that were no longer on it, who got the drug CPI-0610 14 days in a row out of a 21-day cycle, so 3 weeks of a cycle, 2 weeks they got the drug, versus those patients who were already on ruxolitinib, who were able to get the drug to try to salvage response. Maybe they're having a bigger spleen, worsening symptoms, etc. And then those patients ultimately who were naive to ever seeing ruxolitinib, who would get the 2 drugs up front. And whether you're transfusion dependent or independent would dictate what the endpoint of interest was, making you transfusion independent if you were dependent, or shrinking your spleen if you were already transfusion dependent. And I'll just highlight part of it because this was a whole big study to begin with, and I'm just trying to give an overview with some detail to give the viewer a sense of what one can expect. And this is data that's already been presented, and there's actually updated data. But for the purpose of this talk, what I want to point out is that what we saw, for example, in cohort 2A, these were patients who were on ruxolitinib, who had lost response or were losing response to the drug after being on the drug. If you added this CPI-0610, in some cases there were significant reductions of the spleen volume, improvements in the symptoms, and sometimes that was really satisfying because you could see it within days to weeks of treating patients with this drug. And most patients, this is called the Patient Global Impression of Change score, most patients reported that they felt better in some way, sometimes minimally, sometimes much improved, and in some cases very much improved. What we also saw was that 6 out of the 14 patients who were transfusion dependent became transfusion independent, and almost 40% of patients that were treated had reductions in bone marrow fibrosis. So what this really tells us is that the mouse model was helpful, understanding the mechanism of the drug was insightful, and then taking it safely into a patient population, because this was a well-tolerated drug, showed us that there were definitely responses that can be enjoyed by patients based on this science. Here's a shot of a waterfall plot of patients who got the drug with ruxolitinib up front, so they were naive. And what was nice about this aspect of the study was 80% of the patients, and it may not be 80% ultimately, but a vast majority of patients enjoyed a very significant spleen volume response that is likely to be higher frequency, perhaps even more depth of spleen response than Jakafi alone. And for that reason, the drug will now be evaluated in a randomized phase 3 study in patients who are JAK inhibitor naive, and that will be called the Manifest-2 study, which will be coming to a clinical center close to you likely in the near future. And this is an example of an epigenetic therapy that can be added on to Jakafi, or in this case, used with Jakafi right from the onset to try to get more bang for your buck. And that's the study design of the randomized phase 3 study that's still under development, but it would be adding the CPI drug to Jakafi versus placebo as a control. And unfortunately, many patients do get frustrated with this aspect, and I know everyone on this call appreciates that to adequately evaluate drugs, one needs a control arm in a prospective fashion to demonstrate that the benefit that one is seeing in the experimental arm is true, and the control arm serves that purpose. So patients would go on, in this case, patients would get standard of care, ruxolitinib. They would not be treated, but they would get a placebo instead of getting CPI in the patients who are on the experimental arm. It's important to also mention that there are other drugs similarly that have shown some impressive results. This is the navitoclax data that was presented. Navitoclax is a BCL2 BCLX inhibitor, and this is a drug that's also oral and is important in trying to affect proteins in the cells that govern a process called apoptosis or programmed cell death. And what we've learned is many cells, many diseases, including myelofibrosis, depend on the cells upregulating these BCL2 proteins so they can stay alive. And of course, we don't want them to stay alive. So what we do is we give drugs that blunt or affect that activity of that protein and try to induce them or encourage them to commit suicide and die, hopefully selectively. And in doing so, again, what we always look at in clinical trials as a marker of how well we're doing with the drug is reduction of spleen volume. Again, this is the waterfall plot. So you want to see the bars going below 0. That means reduction in spleen volume. And you can see that many patients enjoyed, and again, here's the magical 35% spleen volume reduction. You can see many patients enjoyed reduction below that, although some patients had increases in their spleen volume. I think it's notable that this drug can also similarly deliver spleen and symptom improvement, and in some cases also reduction in bone marrow fibrosis. One difference perhaps with this drug is that it may induce more thrombocytopenia or lowering of the platelet count, and that's why it's always good to have multiple choices, I think, ultimately available to our patients. And this drug will also move on to phase 3 testing both upfront and second line. I feel like I can't do a talk without mentioning imetelstat. This is a very interesting drug, which is an intravenous drug. It was evaluated in a study called the EMBARK study, which was a phase 2 study looking at 2 different doses of the drug. This is a drug that is different than a JAK inhibitor. It's different than an epigenetic drug like CPI. It's not a BCL2 inhibitor. It's a drug that inhibits an enzyme called telomerase. And telomerase is an enzyme that's upregulated, that's elevated all the time in myelofibrosis stem cells, but only sometimes in normal stem cells. And whenever you have a difference in the biology of disease cell versus a normal cell, it gives you an opportunity to try to take advantage of that from a therapeutic sense, and that's what this drug does. It inhibits the enzyme, and in doing so, it inhibits the ability for the enzyme to add what are called telomeres, or caps to DNA. And what happens is when cells divide, those caps get shorter and shorter and shorter, and you get to a critical point where the cell can no longer divide. And what patients, myelofibrosis cells that have telomerase, they allow these caps to continue to extend and therefore escape a mechanism that would normally tell them, hey, you've outlived your value, it's time to die. And that's one mechanism why malignant cells are able to stick around. So this takes advantage of that concept by inhibiting that enzyme and helping that cell realize that it's time to die. It's given as an intravenous infusion every 3 weeks. And what was shown in this study, I think that was quite unique and worth noting was, although the spleen and symptom responses shown here were modest, 10%, and 37% is not that modest second line. These are patients who are quite sick with failed ruxolitinib, Jakafi, who had worsening spleen, symptoms, who had high molecular risk mutations you may have heard of like ASXL1, EZH2. In some patients, they were considered triple negative. They didn't have the classic JAK2, MPL, or CALR mutation. And these were patients in dire need of treatment. And what we saw was that even if the patients had a median of 8 cycles or almost 32 weeks of treatment, there appeared to be a survival benefit. Many investigators have looked at the data and have seen that patients with myelofibrosis who ultimately fail ruxolitinib, who come off ruxolitinib because of progressive spleen, worsening blood counts, for whatever reason that is legitimate, often don't do well. And we know that the survival of those patients are then limited. So improving survival is obviously an endpoint or an important goal of therapy, perhaps beyond spleen and symptom in some patients. And that's why this drug becomes quite interesting and quite important, because you can see this is called a Kaplan-Meier survival curve. You can see that there's a separation here of the two curves. And the median survival of the patients who got the higher dose, the active dose of the drug, was 30 months versus 20 months in the patients who got the lower, less active dose. And subsequent studies have shown that the mechanism of the drug and certain markers that would predict, what are called biomarkers, the response to this drug, also associated with response and survival. So this is a totally different way of treating myelofibrosis patients. This may not be for every patient. This may be for patients who are looking at a window and trying to get to transplant, for example, and trying to reduce the amount of disease. This may be for patients who are trying to live longer as a goal of therapy, and this may not be for an 89-year-old myelofibrosis patient where symptom and spleen is paramount. So it's really something that would have to be discussed with your provider, with your physician, and this study will now move into a phase 3 study shortly and go for an endpoint that is overall survival. Lastly, just a discussion about myelofibrosis. So patients often say, well, I have myelofibrosis. It's fibrosis or scarring in my bone marrow. Can we affect that? Can we improve that? And that should improve the way my blood counts behave and how I feel. And that's an understandable way of looking at things. And we know that part of the process of myelofibrosis is mediated by a protein called TGF-beta, which is produced primarily by malignant myelofibrosis megakaryocytes. These are massive cells that look abnormal in the bone marrow that make platelets. And we know they're central to the pathology of this disease. And TGF-beta 1 levels have been shown to be elevated, and multiple studies have implicated in the pathogenesis of the disease, both in promoting fibrosis, but also in negatively regulating normal hematopoiesis, meaning the TGF-beta expression promotes scarring in the bone marrow, but also suppresses normal cells from creating normal blood cells. So there's an interest in targeting that, and there's a drug by a company called Forbius called AVID-200, which is a selective inhibitor. It's an antibody that binds and neutralizes and soaks up TGF-beta in the blood and the bone marrow, so it can't signal, and thusly allowing for hopefully normal blood cells to develop and reducing the production of fibrosis. And this is an ongoing clinical trial through our research consortium that Ruben and Aaron are actively involved in, and Claire has been involved in for many years. And this is a phase 1 study that is ongoing that I'm excited about, and it's an IV drug that is given every 3 weeks with the goal of trying to improve blood counts, spleen symptom, but importantly, reduce fibrosis in the bone marrow. Lastly, and I promise this is lastly, KRT-232 is an important drug because it is a drug that belongs to a class of drugs called MDM2 inhibitors. And MDM2 inhibitors are drugs that negatively regulate a very important protein for all cell fate called P53. The most common mutated or altered or corrupted protein in cancer is a gene called P53 that codes a protein called P53, which is the master regulator of cell fate. It affects transcription or expression of genes. It affects multiple aspects of cell survival and signaling and proliferation. And we know that in myelofibrosis patients, the majority of patients do not have a P53 mutated gene, but we know their P53 pathway is not functioning appropriately. And we believe that in great part that's due to the upregulation of a protein called MDM2. So this is a drug that binds the interaction between MDM2 and P53 and allows for P53 to do what it should do, which is in a corrupted malignant cell, is to tell the cell to die, to undergo apoptosis. And this study is looking at patients who have TP53 wild type, so not mutated gene, who have myelofibrosis, who have failed a JAK inhibitor, and you'll notice it's a common theme of second-line therapy, given the drug in different schedules and cycles. And its data has already been presented at the European Hematology Association, which I won't go into due to time. But this drug also seems to have activity both in spleen and symptom, and we're anxiously awaiting mature data to get a sense of how promising this drug could be either alone in this study or in subsequent studies are now being done in combination with Jakafi. So a different type of approach. So in conclusion, Jakafi, ruxolitinib, and fedratinib are approved JAK inhibitors. You can use these drugs either first or second line. They definitely offer benefit to spleen and symptom, but we know we don't cure patients with these drugs. That's why everyone on the speakers on this call are interested in developing therapies that improve our patients' lives and hopefully extend our patients' lives. Drugs like pacritinib and momelotinib are JAK inhibitors that might find special places that Aaron can then put into the NCCN guidelines eventually when they're approved for low platelets for pacritinib or for anemia with momelotinib. Luspatercept is a drug that we use in a cousin of myelofibrosis, myelodysplastic syndrome, to improve anemia, and one day may be available and is in clinical testing for anemia. And then lastly, there are a number of very exciting approaches which I've tried to outline and not overdo. But I think the take-home message, as I've said to similar audiences in the past, is there's a lot of clinical development. There's a lot of interest both from scientists in the laboratory, clinical investigators, pharmaceutical companies, and funding, which makes me feel optimistic to be involved in this field and to be present and be part of this group here. That in short order, or I would like to think in short order, we will continue to make improvements and deliver better drugs and more promising drugs to our patients in the clinic. And with that, I'll end. I'm sure I'm over, and I'm sure I'll get comments like I spoke too fast and I gave you too much information, but so be it. So thank you, Joanne, and everyone else for including me. I'll stop sharing promptly.
Well, wonderful. Well, this has been a tremendous discussion, several fabulous talks. We find ourselves basically at the end of our time, but I think that it's really been a phenomenal set of discussion that hopefully has answered in advance, many of the questions that would have come up. I'm very mindful of our colleagues that are coming both post-clinic, as well as dear Claire Harrison that is doing this well past midnight in London time. I think there were some pre-submitted questions. I will debrief with Joanne and others. I think there's clearly an important need for some ongoing educational events, as well as we try to plan perhaps for a longer event later in the year or over the winter, with some time for some virtual breakout groups and things of that nature. There's one particular question that I've already gotten from every patient that I had today, so I'm going to ask Claire this question. What do you suppose vaccine guidance will likely be regarding COVID-19 for MPN patients? I think you're on mute, Claire.
That's the cardinal sin, isn't it? That shows that it's past midnight here, really, right? So first, I think that it's really amazing how much the development of vaccines have been accelerated. I changed my role in the COVID crisis to run the COVID research for our hospital, and was really bowled over. We had 550 staff roll up their sleeves and get vaccinated in a randomized study in 2 weeks. And there are now something like 30,000 patients on the Oxford vaccine study. I think likely we will have several COVID vaccines ready. Quite how effective they'll be, it will be difficult to know, but likely there will be several of them. And actually, I think one concern that was raised by MPN patients in London and then this evening in Austria was, will MPN patients be able to have the vaccine, even if it's a live vaccine? Because often we recommend against live vaccines for MPN patients. And the answer to that is yes. We know that you're probably more susceptible to this condition, and you would be able to have the coronavirus vaccine. Until such time, however, as we have the vaccine, please do remember to take your annual flu vaccine, because this is really, really important, especially this year. Although we're all social distancing, washing our hands, wearing masks, etc., and we may see less flu. There's been less flu in Australia and Turkey, for example, already. But please get your annual flu jab. It will save you from having a fever and having a COVID swab. And it will also spark up your immune system and enable you probably to fight off this virus if you are unfortunate enough to have it. I'm sure we will have a coronavirus vaccine. Quite when, whether it will be, early next year or not, I'm not sure, Ruben. I'm not even sure if I've had it, even though I was in the study. I was randomized, but I have no idea.
Well, wonderful. Well, I agree with your comments entirely. I think we will certainly try to, maximize the effort for everyone to be able to receive the protection of the vaccine. And by the same token, I suspect a vaccine that will be widely distributed likely would be safe enough for most people to receive. It clearly would be counterproductive to have wide distribution of a vaccine that those most in need of the vaccine, individuals that are immunocompromised, etc., would not be able to receive. Well, again, it's been a fantastic discussion. Let me hand it over for any final comments to Joanne and David before we let our panelists get some well-deserved rest, as well as have all of you have a lovely evening.
Yes, well, I wanted to thank everybody for registering, for showing your interest in coming to the event, and for participating and supporting the MPN Education Foundation. And thank you to all the speakers. We really do appreciate the amount of time that you devote to us, and the excellence in the presentations.
And Joanne, I want to jump in just briefly to say I think we've met our goal of leaving the focus on the substance of this meeting, but we do want to thank those of you who made very kind donations to the MPN Education Foundation. We are different from the very worthy MPN Research Foundation and appreciate your support to help us provide education in accordance with our mission. And we hope to see you early next year when we have a longer program for which this was, I think, a very successful test. Thank you very much.
Great. Everyone, take care.
Thank you. Bye-bye.
Bye-bye.
Thank you.